um, a colleague from Thailand who's a hematologist you've met before from named Zen. She's at used to be at Surat, but she's now been training in the United States, and she's joining us for a month. So on the ward, so we're another person, our third person to visit us here in Portland.
Who is she?
Um,
What is her
her,
name?
I'm gonna well, I'm gonna have she'll be on. Hopefully, she'll get on the phone quick. Um, I'm gonna have trouble with her phone. She goes by her name Zen Kanithamanian.
Oh,
Can it Hamnion?
oh, I don't know.
All right. Well, she was
Where
a
is she from?
well, she trained at Suryat, Siraj, and was on their staff for a year as a hematologist, but
Dr.
then is
Zen.
now has come to U.S. to retrain in internal medicine, and she's at Texas Tech, and she's spending a month with us in doing CAR T therapy and bone marrow transplant.
I see. I see.
So,
I see. Good,
um,
good, good.
so we
And
do
also,
have a lot of folks on the call. I think this is good. Dr. Denny's
That
on the
is nice.
call.
Yeah, very good.
Yeah, Dr. And for everybody on the call, I just want to, I'll just jump into it and say, one,
yes.
good to see and hear your voices again.
Mhm.
Um, I've invited Dr. Myers. Dr. Myers is a professor at OHSU and has been here not as long as me, but I think she's a third longest tenure person in our heme malignancy specialty for and she's a superb transplanter, has been interested in bone marrow failure and myelodysplasia for years, but I'm going to say 3 or 4 years ago, decided to go back and recognizing if you take care of myelodysplasia, it's an older population. I'm going to put words in her mouth, but it seems like this might be a population better to understand how to handle older patients. So she went and took in effect, the equivalent of a sabbatical to get a fellowship in geriatrics. And during that
Mm.
time, I think she's focused at the problems of geriatrics patients' experience during transplant that led to a lot of very interesting research that's as well as efforts that she's now led across America in recognizing these new issues in the transplant space. And with that, I figure from here she's going to explain all that to you. So Dr. Gabrielle Myers is going to speak today and share with you thoughts on the titles acute cognitive changes with transplantation. So thank you, Dr. Myers, for taking the time out of your day and week to share with our colleagues across the ocean.
Yeah, well, thanks for that kind introduction, Richard, and I really appreciate the opportunity to talk with you all today. I could spend, many, many hours talking about cognitive changes in our cancer patients, in our transplant patients, both, before coming to transplant, after, and, even thinking about long-term risks of cognitive changes. But today I'm going to talk really about acute cognitive changes happening in the early time points of hematopoietic cell transplantation. And as I'll talk about, really focusing not only on allo patients, but also auto patients, and then also thinking about not only older adults, which I think is our first thing we go to when we think of cognitive problems, but really thinking about the whole age spectrum, because it is important in pediatric populations as well as sort of middle-aged people as well. So my goals is to really talk about acute cognitive changes in transplant. And then what we created was really a name for this and what we've called TAME. I'm going to talk about TAME, so transplant-associated altered mentation and encephalopathy, and then talk about how do we diagnose TAME, what may drive TAME to happen, how do we manage it and kind of think about it, and really also thinking about kind of bigger picture future efforts in trying to figure out how to support our patients, reduce cognitive complication rates. So I'm going to start with a case, and this is a 22-year-old male who has relapsed lymphoma, and he was admitted for a beam conditioned auto stem cell transplant. So he's now day 11, And his transplant course so far has been complicated by grade 3 mucositis, nausea, vomiting, diarrhea, and poor oral intake. So kind of a classic story for our auto transplant patients. So you come in the morning to round, and overnight he acutely developed this confusion and agitation for the nursing staff and his mom, who's also at the bedside. When you see him, he's disoriented. He's thinking it's the start of school. He's thinking it's 2017. He's really kind of trying to get out of bed to go to class. He's kind of stressed about not being able to get to school and wanting to get to school. On vital signs, he's very tachycardic at 156, but it's regular. His blood pressure is 98/55, so on the lowish side. And then what also is kind of notable in this course is that he has these episodes of agitation, but then also has these episodes of somnolence, kind of minimally responsive to questions at time. Not an acute change, but throughout seeing him multiple times. And he's unaware of the days of the week, the months of the year, and he's unsure of where he is. So what are we worried about in this patient? We're worried about a lot of things in this patient, right? And as I'll talk about, when you have a patient that has an acute cognitive change, I think there's a lot of things that go through our head in this vulnerable patient population. And that's, again, the appropriate thing is we should be thinking about what kind of bad stuff is happening and what are things that could be causing this cognitive change. So an acute cognitive change, one word for this is delirium. And delirium is a term that's been used. It's got a diagnosis, as I'll talk about, and that has allowed it to be studied well. So delirium occurs in hospitalized patients. It also occurs in post-surgical patients. And again, not only in adults, but also in pediatric population. And this is really an acute alteration in cognitive function. The delirium is defined by DSM-5 criteria, and it involves altered awareness and attention, and then an acute change from baseline. Plus, with delirium, there's also this fluctuation. So at one time point early in the day, a patient may be one way. Later on, when you see them, they may be a different way. So that fluctuating is actually a very important part of delirium. And then there's some additional cognitive disturbance besides awareness and attention. So oftentimes memory or executive function is poor. And then the delirium happens in somebody that does not have a pre-existing neurocognitive disorder. So if somebody has schizophrenia, for example, and they have an alteration that meets this criteria, we wouldn't necessarily call it delirium because they have a pre-existing neurocognitive disorder. So these are really patients that don't have that develop these acute changes. And it's really a consequence of a medical condition. So we don't think of delirium as necessarily happening in the clinic, for example. It's really something that is happening in the setting of some medical condition, again, whether that's surgery, whether that's another procedure, whether that's just a hospitalization for a variety of reasons. When we think about delirium, there's really three types. There's the hypoactive delirium, which is the most common in cancer patients and the most common overall, we think. And it's often overlooked because really patients are quieter, they're sleeping more, they're not disruptive at all. And so that can be a group that can be missed because they are kind of quiet, not requiring a lot of attention. Very different from our hyperactive delirium patients. These are people that are confused. They can sometimes be aggressive, agitated, and they may even be potentially a harm to themselves or others. And then you have mixed delirium where people really have had episodes of both hyperactive and hypoactive delirium. And again, part of the diagnosis of delirium is that variation, that fluctuation in cognitive function, as I talked about. And so very common to see these variability at different times throughout the day. As I mentioned before, delirium is seen in both children and adults. And it's driven by a combination of things, but we really think about environmental factors, we think about medical factors, and then other physiologic factors. If you remember one thing from this talk, thinking about delirium as being maybe the only clinical manifestation of a physiologic stressor. And so whenever we see patients that have this acute cognitive change, always thinking about what is wrong. Are they developing sepsis? Are they having an MI? Is this a stroke? What is causing them to be this way? What sort of physiologic stressor is presenting as delirium? And again, so it's really a clinical manifestation of some type of stressor. And when we look at outcomes in patients that have delirium versus those that don't have delirium, the outcomes are always worse in patients that have delirium. And again, that's in all patients studied. If we look at delirium specific in cancer patients, again, delirium is surprisingly common in cancer patients when it's looked at. And again, primarily hypoactive delirium is how this is manifest in many cancer patients. There are a few recent studies about cancer patients that I thought were very interesting just to comment on. So in Korea, they looked at medication use prior to hospitalization in cancer patients and their rates of delirium. And those that had some sort of central nervous system active medication, the delirium rates were 22.2% versus 14% of those who were not on medications. And again, this included opioids, it included antidepressants, it included benzodiazepines. When they looked at specific drugs within that class, opioids and antidepressant use were significantly associated with increased delirium risk. And if people were on 3 or more CNS active medications, they had a markedly increased risk. It was like a hazard ratio of a 7 or 8, so very high. So one of the things that we know in the world of delirium is that medications can be a contributing factor. We oftentimes think about medicines we use in the hospital, but this is just to say medicines that people are using before they come in can be contributing to the risk of delirium. And I think there's a lot of things you could argue about this, right? In the sense of if somebody is on opioids as an outpatient before coming into the hospital, that might be a sicker population. This may be a different population that's needing CNS active medications. So they didn't get into some of those finer details, but I do think that thinking about medicines people are on becomes important. In Brazil, I thought this was also a very interesting study that looked at cancer patients in the ICU and the long-term impact of delirium on their kind of overall treatment course for their cancer. So they had, this was it taken place in a cancer-only hospital that had an intensive care unit with it. So they had a lot of patients that were studied in this paper, and they saw almost 17% of patients had delirium. What they found was that patients that had delirium had a change in their long-term cancer treatment program. And that led to a change. That change in treatment was associated with an increased mortality at 1 year. With that, you can see that ratio of 2.68. So significant increase in mortality associated with delirium, and in part because these were patients that had lost functional status, were not able to get a more aggressive treatment plan and kind of changed the focus of treatment. And so just to say that delirium can have both these short-term consequences, long-term consequences, and there are these factors that play into delirium development. If we're now just to say, let's look at delirium in transplant patients. And when this has been studied, we see that this is actually even more common than those numbers I gave on the last slide for all cancer patients. So in the 1990s and early 2000s were when some of these first studies were done at delirium in transplant patients. And when it was studied very kind of particularly, they found up to a 70% incidence of delirium in transplant patients. These were older studies, but everybody on the studies were receiving myeloablative conditioning. And overall, this were actually kind of a relatively younger population because everyone was receiving myeloablative transplants. These were primarily patients in their 40s and 50s, if not younger. Kind of average age was around 40s to 50s. When we look at some newer studies that have a broader age population and includes patients receiving reduced intensity conditioning, we also see pretty high rates of delirium as well. And then just to say, in the pediatric population, there's a single institution actually done at our institution where they looked at delirium in transplant and pediatric oncology patients. But when they pulled out the transplant group, they found 23% delirium rates during that transplant hospitalization. There was a larger multi-institutional study looking at delirium in pediatric transplant patients in particular, and they found that 45% of patients qualified as having delirium. So again, very common overall in transplant patients and including pediatric and adult studies. These studies on delirium and transplant have identified some risk factors, and these risk factors become really important in thinking about what's modifiable potentially. Some of those are patient-related factors that may or may not be modifiable. Some are treatment-related that are potentially modifiable, and then some are environmentally related, again, that are potentially modifiable. But in the paper that we put together, we had a table, and just to talk about risk factors for delirium, and again, sort of this middle column is really thinking about delirium in non-transplant, non-cancer patients. What are some of the risk factors? Some of which may be relevant to our transplant population, and then thinking about these studies that were done with transplant populations specifically, what did they find? So you can see age is on top, both really young and older adults, that age does impact. The second thing is that lower cognitive function, again, seen both in transplant and non-transplant populations. One of the things that is really moving in the field of transplant in general is really understanding cognitive function coming into transplant, because as we study it, number one, it's amazing how many patients have some level of cognitive dysfunction coming into transplant. And again, the rates are higher as you get older, but the rates are surprisingly high even in kind of our younger populations when we look. Number two, kind of everybody that studied lower cognitive function coming into transplant has really identified that as an important factor in impacting outcomes. So a big push now to really think about how we can understand people's cognitive function coming into transplant, and then what are things that are potentially modifiable, or is there a role for kind of a cognitive therapy before transplant, and could that impact outcomes? And then other things on the list, some of which these kind of make sense. Somebody that has sensory impairment or history of delirium, kind of depression, a history of falls. And on this, kind of on both sides is really this idea of lower physical function, and whether that's a lower level of activity that's been seen in the non-transplant population, this lower physical function that has been seen in transplant population, or falls within the last year as a marker of poor physical function. So we know that poor cognitive function, poor physical function, both can increase delirium rates. So there is this importance of physical function and delirium rates too. And then also thinking about other comorbidities such as renal dysfunction, higher comorbidity index, hepatic disease, and then polypharmacy is important too. So these are patient factors, and again, many of these are not necessarily modifiable, but important to think about from a risk assessment. And then thinking about the treatment-related factors that can increase delirium. And again, are these things that we could maybe modify? So again, in our non-transplant population, thinking about metabolic derangements, dehydration, poor nutritional status are all, critically important. Admission to the ICU also increases your risk of delirium, indwelling catheters, and then pain, in particular, poorly managed pain, is really a high-risk feature for developing delirium. In transplant patients, the big things that we think about Our medications obviously are associated with delirium, and you can see the list is pretty long as to medications that are associated with delirium. And these are medicines that we may use very frequently for either symptom support, pre-medications to try to prevent complications, and then, of course, our medicines like steroids and tacrolimus that are critical for graft versus host disease prevention or management. HHV6 has been associated with delirium in transplant patients as well, and that, I think, kind of makes sense. But as I'll talk about, again, thinking about being mindful of medications becomes important in thinking about acute cognitive impairment with transplant. And then finally, these environmentally related factors, the use of restraints, disrupted sleep, lack of family or caregiver visitation in the non-transplant world have all been associated with delirium. One of the things that I know we do very well is we are very good at disrupting sleep. Unfortunately, we do a lot of kind of assessments around midnight, draw labs, do assessments at 4 a.m. And then oftentimes the labs come back and then we get electrolytes started or transfusions started. And I hear a lot from patients in the hospital, like, the sort of the middle of the night, if they have to do an assessment or vitals, sometimes they'll say, oh, they were really great. They just came in, they were quiet, they didn't turn on the lights, and they did my vitals, and I went back to sleep. Sometimes they say, they walked in and they flipped on the lights and they're like, we need to do a wait, and it's 4 a.m. and, kind of very, very disruptive. So again, factors that we can potentially impact or thinking about how we, and not every patient's going to be the same, but are there times where we can think about not being so disruptive to patients in the hospital is an important factor in thinking about delirium. So when people have delirium during transplant, like I said, these studies have also looked at outcomes of the people that have had delirium going through transplant. And again, increased complications and poor outcomes are what have been seen in the world of having delirium with transplant. And in particular, there's an increase in non-relapse mortality. There's a higher one-year mortality. And then also worse post-transplant cognitive function. Higher rates of treatment distress. I don't know if you have ever talked with patients that have had delirium, but for a lot of them, they may not remember anything at all. They'll say, like, my family tells me stories about what I was saying or what I was doing. I don't remember any of that. It's pretty stressful and it's very distressing to them. Sometimes people will have very fixed ideas of something happening, kind of these nightmarish episodes that they feel like happened in the hospital when they were having delirium. So there can be a high level of distress associated with it. And a decreased health-related quality of life has been seen as well in patients with delirium. So it's a serious and common complication. And so we felt like there's a need for better identification in our transplant patients in particular, as well as a systematic approach to evaluating transplant patients. And so that's why we developed these guidelines and came up with this diagnosis of TAME, this transplant-associated altered mentation and encephalopathy. And the goal is really to capture acute cognitive changes at any time point during their transplant course. We know that most patients that have delirium will get that early in their transplant course, and so we wanted to identify those patients. But we also see patients that may come in down the road with a flare in graft versus host disease, for example. And that's also a population where we can see delirium develop. And so that's why we wanted to differentiate acute and, early and late TAME, because there may be the same pathophysiology, but maybe different pathophysiologies of those two components. And so we really wanted to separate them out. In addition to delirium, which I've been talking a lot about, there's also, especially in the world of ICU care, there's also this movement towards identifying patients that don't meet all of the criteria of delirium, but actually have a lot of features of delirium. And this is a group called subsyndromal delirium. And so because the ICU world is including them in their studies, we wanted to include them as well. And so TAME has a larger umbrella of capturing both pure delirium as well as subsyndromal delirium, as I'll talk more about. And then we want to use this diagnosis for research purposes so we can understand who gets it, why do they get it, and how does it really impact them short-term and long-term. Besides giving it a name, I think one of our goals of this guidelines was really to say there should be additional workup and treatment and management based on what we know in the non-transplant delirium world, and then ultimately thinking about preventative approaches too. So this is kind of a busy diagram, but really trying to capture what that TAME diagnosis is all about. So if you start on kind of the right-hand side, this acute encephalopathy in a transplant patient. So what acute encephalopathy really is a rapidly a rapidly developing pathophysiologic brain process. And what we know can be an acute encephalopathy is coma, but we wanted to take that out of the picture. So coma is kind of to the right, not part of TAME. And then that acute encephalopathy is clinically expressed as either delirium or subsyndromal delirium. And for the delirium criteria for DSM-5, you really have to meet kind of these three criteria: this altered awareness and attention, acute change from baseline and fluctuating, and then additional cognitive disturbance, as I talked about. So if you meet all three, you have delirium, but if you only meet two of the three, you'd be considered subsyndromal delirium. And we wanted to capture all of those patients in our TAME umbrella. Some patients with acute encephalopathy will also have seizures or extrapyramidal signs. And so again, just to acknowledge that those can happen, but they're not part of this delirium or this TAME diagnosis. And as Richard had mentioned, and I did also with my slides, I sent out this guidelines paper that all of this is based on too. So thanks. And I will just keep on talking unless somebody interrupts me. So if you have questions, please chime in. Happy to answer any questions. But again, this idea that you have kind of a pathophysiology, this acute encephalopathy, and that's clinically manifesting. What are we seeing it as? We're seeing it as delirium, subsyndromal delirium, or coma can also be a manifestation too. So this is just to talk about this in a little more detail. And so rapidly developing, really thinking of less than 4 weeks. And delirium, like we talked about, meeting that DSM-5 criteria of those three primary features, and then 2 out of 3 for subsyndromal delirium. And as I talked about, the TAME really includes those. So this is just what I had mentioned. What we did here, and this is in the paper, but I also wanted to put it on the slide to just say that kind of on the right-hand side, these tools to evaluate patients and how these DSM-5 features may show up. I just wanted to talk about this in our transplant patients. You know, this idea, and I think we've all seen these patients, right? We kind of walk in and they're, to see them in the morning, sort of drowsy, they're a little bit stuporous. And sometimes you sort of wake them up. Hey, the team's rounding. Good to see you this morning. How are you doing? And sometimes they kind of pop up and they're like, oh, I'm doing okay. They know they're in the hospital. They have a good conversation with you. But then there are those patients that don't really wake up all that well. When they wake up, they are confused. They may not know they're in the hospital, and they have the kind of difficulty remembering conversations or following directions. One of the ways to evaluate that group of patients, or anyone that might seem a little bit drowsy and you're kind of worried about cognitive function, is you can just have them do the weeks of the days of the week kind of forward and then have them do it backwards. So really that attention requires doing things backwards. And I think that I'm always surprised. Somebody can even have a great conversation with somebody, and then if you ask them to do some of these tests, they actually won't be able to do them very well. Or I've had the converse happen where I'm like, oh, this person is not going to be able to do it, and they do it just fine. So, so kind of asking some basic knowledge questions, but then flipping it so they do things backwards is important, because having to do things backwards is really takes a lot of attention, and attention is one of those key pieces of delirium. And then the second piece is these new changes in attention and awareness they're new. They weren't present earlier in the shift. They weren't present before they came into the hospital. And then this idea that there's this fluctuation, right? So the nurses might say, hey, they were this way. And of course you walk in and they're very different. And then the family member, talks with you later and they're different again. And so this fluctuation and this change in their cognitive function is very classic for delirium. So really, everyone is to be believed, because patients really can shift quite a bit when they're delirious and have these moments of real clarity, and then moments where they're not clear at all and they're very confused. And so nursing staff can be really helpful with this. Family members also can be very helpful in understanding that fluctuation that might be happening. And then some additional disturbance in cognition, whether that's memory, disorientation, language, perception. So you can have them recall a couple of words. You can have them kind of copy a three-dimensional figure. You can have them describe their surroundings, tell you about their current medical condition. Why are you do you know that you're in the hospital? Do you know why you're in the hospital? So some quick questions can really assess whether they have some other components of their memory or other components of their cognition that are impacted. And then as I talked about thinking about early TAME and late TAME, really we wanted to say that 100 days post-transplant was really the timing differential between early and late, since that's such an important factor in so many other features. And so if you're within the first 100 days of transplant, you're early TAME. If you're over 100 days from transplant and you have some other transplant-related complication, then we would call that late TAME. So these are the patients that have graft versus host disease or infectious complications, or maybe relapse of their disease. The people that have are still on immune suppressive medications, whatever that might be, and they have TAME, they would classify in that late category. And the diseases that are inclusive in TAME, so people can have TAME plus, and they really have TAME plus, so what's the other factor that's driving? Metabolic encephalopathy, is it sepsis? Is it steroid-induced cognitive changes? And so this list is not exhaustive, but we wanted to really recognize that there are a lot of things that can cause acute cognitive changes that are seen with TAME. And we would really want both of those diagnoses flagged for patients, again, so that we can understand TAME better, understand diseases associated with TAME, and then help us to think about both preventative and treatment pathways. So in thinking about screening and identification of TAME, so the highest rates of delirium are on days 10 to 18 post-transplant. Again, a time where people are often sick. This is data from the post-transplant cyclophosphamide era, just to say that. And with the integration of post-transplant cyclophosphamide and knowing that CRS can happen with that treatment program, TAME might look a little bit different, and we might actually now see that TAME starts at a very earlier time point in patients with post-transplant cyclophosphamide. So that's just a caveat of something that we're researching and trying to understand better. And then every transplant patient is at risk, younger, older, auto, allo, all. And so this idea of having a universal screening program for all transplant patients is what we would advocate. And we talked about, there are some patients that may be at increased risk for delirium and TAME, and those should be watched, kind of throughout their transplant course. So really it involves this daily attention and orientation assessments, working with the care teams and family to understand how the patients are doing. And then there are formal tools that can be used to assess for delirium. The confusion assessment method, or the CAM, is the one that's most known and most studied. What's really nice about CAM is they now have an ultra fast CAM. They have a fast CAM. They have an ICU CAM. They have their standard CAM. So they have a lot of different CAMs that have all been validated, and those are very useful tools to assess for delirium in patients. There's the delirium rating scale, which was used in some of these older studies. It's a little bit longer. It takes more time. And so it's not very user-friendly necessarily in a busy clinic or, busy rotation. And then in the pediatric world, the Cornell Assessment of Pediatric Delirium, the CAPD, is our gold standard. It's well used. It's actually very easy. It's a short assessment. And so that's really the only thing that's been validated in kids. Do you all take care of pediatric patients too?
There are 2 pediatric transplant programs that also share in this, and I think I saw one of the team members is on the call. There you go.
Yeah. I'm taking care of the pediatric side.
Wonderful.
Yeah. Thank you for your talk. It's very useful.
Oh yeah, you're very welcome. And I think that I thought that there might be some providers that cared for pediatric patients, but wanted to just verify that. So I'm glad you're able to be here.
Yes.
So let's go back to this first case. So our 22-year-old with relapsed lymphoma, day 11 of transplant. He's confused, he's agitated, he's tachycardic, his blood pressure's a little bit low, and you're worried about him. So as far as thinking about the next best step in management of this patient, I'm going to pause here and let you guys look. We'll do a mini test. If you guys want, I opened up my chat. If you guys want to throw answers into your chat, that would work. Or just
For me, maybe all of that.
Yeah, I like it. Thank you. Yeah, right. So we would definitely want to think about all of those things, right? So we're gonna our top priority is sepsis, right? Day 11 patient who's confused. We absolutely need to think about sepsis. When I did years ago, when we looked at our auto transplant patients, many of them actually didn't fever necessarily before they kind of presented clinically with an illness. So kind of the top priority is thinking about sepsis. We're looking at his medications, and then removing any benzodiazepines or other sedating medications. Consider non-opioid treatments for pain are all things that you can consider as well. So is he at risk for TAME? I think you guys probably are going to answer that yes, right? And so does he meet the criteria for TAME? Do you think he has TAME?
Yes.
I agree. And then I think always the big question is why, right? And so, I would say, yes, he's at risk for TAME. He's right in that high risk period, day 11 post-transplant. I think he has TAME plus he has neutropenic sepsis, worried about that. And again, why did he develop? And I think there's probably a lot of potential factors contributing related to his infection, thinking about medications, thinking about the fact that he's been in the hospital for quite a while, reduced activity, disrupted sleep, lots of possibilities and contributing factors. So the kind of why does it happen? Again, delirium is associated with a physiologic stress. Sometimes it's the only manifestation of a serious event. So always thinking about what bad thing is happening to this patient that's now confused. And when we think about diagnosing TAME, we really want to evaluate for acute illness. And so again, in the book, and I just kind of pulled this up just to say that what do we have to think about when we see TAME? We really have to think about CNS pathology, those infections. Are we missing uncontrolled pain? Are there medications that are probably maybe too high or too much for a patient, or a combination of opioids and benzodiazepines that we have to be thoughtful about? And then that sleep disturbance, we know, can be so common in our transplant patients. And so watching and evaluating for that. As I talked about, delirium comes in 3 types. And so when we think about potential complications for transplants, when you have a hypoactive delirium patient, a patient with hypoactive delirium may not take their medications very well. They're not going to be getting out of bed, moving around. And so there are factors like non-adherence to critical medications, a functional decline because they're spending more time in bed. Really, malnourishment can happen. And then there's also this excessive diagnostic testing. We may be doing lots of screening to try to understand increased morbidity and mortality due to falls, development of pressure ulcers, aspiration pneumonias. And like we talked about, we know long-term, these complications of increased non-relapse mortality have been seen, as well as higher 1-year rates of mortality. So we know there's these short-term complications because these patients can be a real challenge to manage in the hospital just because they're not moving forward because they're cognitively so blunted. There are times where patients with TAME can be a harm to themselves or to others, or can have very distressing hallucinations or delusions. And that's a time where antipsychotic use is appropriate. This table talks about kind of dosing, but in thinking about older adults in particular, you really want to start with low doses, and we have to be thoughtful about which medications can be used, which formulations drugs come in. So that's but the idea is that if you have a hypoactive patient with delirium that is not waking up, they don't necessarily require treatments with antipsychotics. But there are times where you have somebody that's aggressive or having really intense delusions, and that's a time where antipsychotics are very appropriate. So thinking about our prevention and management, those strategies kind of work together. Treating the underlying stressor is important in management. Having good pain control throughout the whole procedure not only helps with prevention of delirium, but also management of delirium. Because sometimes if a patient isn't able to verbalize well, their kind of nonverbal manifestation of uncontrolled pain may be delirium. Minimizing tubes and lines, adequate nutrition. And this can sometimes be a challenge where you have somebody that's not eating well and you think about, gosh, do they need a Daboff tube? But they're confused, and putting in a Daboff tube will probably make their confusion last longer. So that can sometimes be tricky. Trying to get a routine established is important. Kind of that normal wake-sleep cycle is very important in helping not only with prevention and management. Getting familiar people, family members, getting them out of the room, mobilizing them, and then optimizing sleep quality is also all important features for prevention and management. And we, in our paper, put an approach to improving sleep, and some of these are very basic. Like I talked about, clustering care, trying to have some undisrupted sleep, having the lighting mimic daytime schedules and nighttime schedules versus this kind of 24-hour a day that hospitals are. Support and encourage those daytime routines. Discouraging napping. We have those patients that are like, I didn't sleep well last night, I just want to nap. And then they nap, and then they don't sleep well at night, and they get their whole cycle thrown off. Those are really a real risk for delirium development. And then we also outline some medications that are can be used, and it can be important to assist in insomnia. But what are the things to avoid? Don't give them benzodiazepines if possible. Don't give them antihistamines if possible. And then drugs like zolpidem and kind of what we call Z drugs are really also associated with delirium, and we should try to avoid those if possible. And because of those long-term risks, that prevention of TAME is really critical. So how can we focus on prevention through identifying the risks? So I think that as we've outlined those risk factors for delirium early on, these are things that we want to try to capture in the pre-transplant period. Because if we see somebody that's had a fall or two, that's somebody that I think would benefit from physical therapy before coming to transplant to try to build up strength and reduce their fall risk and get their functional status better. Same thing with identifying cognitive function, looking through medications. So this idea of kind of pre-transplant testing to impact that risk of TAME is really doing this kind of top to bottom assessment. So this cognitive function assessment, a physical function assessment, nutritional assessment, looking at prescription and non-prescription medications, partnering with the pharmacist and nurse coordinator to look at those things and kind of lifestyle features, and then thinking about caregiver and family support. What can they provide while the patient's in the hospital, after the hospital, to really keep them moving, keeping them eating well, and maintaining good nutrition. And so with these assessments, if you find deficits, this is a pretty busy slide, but the idea is that if you do a cognitive function assessment and you see some deficits, you have to, we would want those investigated because there are some things that are reversible, like thyroid disease or sleep apnea or depression. And then also thinking about referring to cognitive therapy to help support patients. Just like if you have physical function assessments, you see somebody that's weak, let's get them to physical therapy to try to build them up before transplant. Same thing with nutritional assessments. And then when we partner with pharmacists and nurse coordinators and thinking about, could we do some dose reductions of supportive medications? So this idea of instead of using 10 milligrams of compazine at a time, how about starting with 2.5 to 5? Knowing that you can always work up, it's hard to pull back sometimes. So thinking about supportive medications and maybe starting with lower dose can be important for certain patient populations. And then this idea of family-centered care, is that possible? And that's really about having the family members be at the bedside and being involved with the care of the patient during their transplant course. And also talking about TAME with patients and caregivers. That being in the hospital can cause confusion, and here's some ways that we can try to reduce that from happening. So here's a second case, and this was a 63-year-old woman who was admitted with recurrent gut graft versus host disease. So about a year prior, she had had a really prolonged hospitalization for steroid refractory gut graft versus host disease. She got on ruxolitinib along with steroids and tacrolimus. During that hospitalization, she had delirium, and her delirium was just like her graft versus host disease. Her delirium was improving, and subsequently she fully recovered. And she actually was doing great. She went on a trip to Hawaii with her family, and everything was going fantastic. And she was on this immune suppression taper. She got a cold with URI symptoms, also had some kind of urinary tract symptoms, and ultimately wound up back in the hospital with really bad diarrhea and had a bad graft versus host disease flare. And so within 4 days, so on hospital day +4, she was noted to be somnolent and confused by family and staff. And when you talk with her, she's disoriented and she's unable to tell you the days of the week. And so what's her diagnosis? And now she's over 100 days out from transplant, but she's in the hospital with a transplant-related complication. And so this is really somebody with late TAME. And again, what criteria defines this as late TAME is having an associated transplant complication and being more than 100 days post-transplant. And we wouldn't think of that history of delirium as being a criteria that defines us as late TAME, but surely could be an increased risk for her developing TAME. So kind of the next steps for this patient, I think, again, this is somebody that we're going to do all of those pieces as far as looking at her medications. We're going to be trying to get her in a routine. We're going to be getting the family involved and making sure her pain's under control. So a lot of work to be done for this patient to try to minimize her cognitive impairment. Unfortunately, once we kind of did a whole bunch of stuff, her cognitive function got a little bit better, but then it worsened again, as did her graft versus host disease. But I have to say, kind of personally, I was really surprised how quickly she became confused in the hospital. And fortunately, it was not related to a sepsis or a kind of a surprising or an occult bacterial infection. But again, with some of our basic maneuvers, we were able to get her cognitive function better. So I wanted to give a little bit of time to see if you guys had cases that you wanted to talk about or questions that you might have, because I know I've thrown a lot of information at you.
Well, I was going to say, I'll just start by saying that was a great talk, and I'm going to let everyone else answer. But I was going to say, put in one of my pet peeves is scheduled medications, and I'm sure you'd say the same, where someone does something and then he said, "Oh, it helped," and so we're going to schedule the anti-nausea medicine continuously, and they don't put a timeout on it. And so 7 days later, you're still on compazine or you're still on drugs because no one has turned off the scheduled medication. I'd say that's a common hospital thing, but just to bring that to, I think it probably, facilitates the development of these syndromes.
Yeah, I think that's a really important point, Richard, is you're right. And we do this. We're like, okay, they're nausea, they've got terrible nausea right now. We want to really get it under control as best as possible. But, a week later, they probably don't need all of those medicines still for nausea control. Yeah, thanks.
Dr. Myers,
Uh-huh.
so I very much enjoy listening to your talk.
Thanks.
So would you please emphasize on the specific causes of acute delirium that require specific treatment? Otherwise, the patients may die.
Yeah, so great point. So I do think, especially in our transplant population, I think sepsis, and kind of bacterial infection and occult infection is really a top consideration in somebody that has an acute cognitive change. And so even without a fever, these are patients that I would start antibiotics on, get blood cultures, start antibiotics on while you're trying to sort things out, because again, it may be heralding a fever, but that cognitive change may really be the first sign and maybe only sign of sepsis. So I think that's a top priority. We always have to think about some kind of CNS event. So especially in our patients that have a very low platelet count, thinking about could there be a head bleed. Oftentimes patients will have a headache or maybe some focal neurologic deficits, but I think, again, kind of what are the life-threatening things we would want to think about? An intracranial bleed would be top on the list. And so if a patient is stable enough to go down for a head CT to evaluate for a CNS bleed, that's, again, something that I would consider in somebody that has an acute cognitive change. And then strokes, kind of otherwise, myocardial infarction, otherwise, a pulmonary embolism, again, would be some of the big things that we would think about showing up as an acute change in cognition. Oftentimes we'll get, people will be getting labs, but if, thinking about metabolic derangements, thinking about acute kidney injury, thinking about kind of hepatic injury, those kind of organ toxicities would also be on the differential and are critical things to investigate. But I know our practice is to really do those testing so frequently that we typically will be capturing that if it's heading in the wrong direction already. But that would be something to think about if testing hasn't been done. And then in also thinking about medications, so thinking about like our calcineurin inhibitors, our cyclosporin and tacrolimus, sirolimus as well, like is this press? Are these potentially seizures related to too high of drug levels? So I guess that would be the other sort of big thing that I would want to have consideration for in somebody with an acute cognitive change.
Mm-hmm. Have you seen some patients with the TTP?
Yeah, and I think, like yeah, you're right, this kind of transplant-associated thrombotic microangiopathy, that, kind of TTP, TMA sort of realm, absolutely. And my experience is oftentimes this can be driven by our tacrolimus or sirolimus. So yeah, I think that's a very good point, very good one to consider.
Mm. So how can you treat those with TTP? I
Oh,
mean,
well,
transplanted.
yeah, I mean, it's, it's a very tricky complication post-transplant. So our approach for TMA is usually we'll use eculizumab. So we'll use the complement inhibitors, knowing that there's, that these are complement-driven diseases. So if we have there, we will send off testing for complement levels that can sometimes take a few days. And so if their LDH is high, if we're kind of highly suspicious of TMA, we'll get them started on eculizumab right away. And then, like I said, oftentimes we'll have to do some adjustments in their medications too.
Okay, thank you. Thank you.
You're welcome.
So I'll ask one more because it's a good conversation. The transplant-associated toxicities often take time to develop. But we also see now, as we're doing more and more of our CAR T patients in the hospital, very rapid onset of a delirium, which we now call immune cell-associated neurotoxicity syndrome. But like I had a patient just yesterday who said every time she says something, she could see her words on the wall in a big red balloon. And it was happening at 4 o'clock in the morning. Similar, but it's so fast onset.
Yeah.
And do we expect that the same sort of screening is going to pick up these in the future, or is this just this, going to still be, we'll just deal with it on a case by case when it happens?
Yeah, Richard, I think that's a great question. And I think I don't think we completely understand where ICANS is and where delirium is and where the overlap is.
Yeah.
I ran across a paper that talked about screening for delirium and whether that could uncover patients that they then might have like full-blown ICANS. Like, is there really like hospital delirium that's separate from ICANS, and are there ways that you can pull those two out and separate them out? So I think we're in the still kind of the infancy of understanding all of that. And I think that deeper studies of ICANS are going to tell us a lot about delirium, because I think there's got to be some overlapping factors, right? But it's a great question. It's something that is fascinating to me. I don't have an answer yet, but I do. I think our approaches to delirium prevention should also be really useful in CAR T patients, because it could potentially impact ICANS development, maybe.
Thanks.
Yeah.
Well, I think Wanapa had to sort of step away, but I just want to thank you so much for that terrific talk. That was just about as good as it gets and perfectly sort of timed for our time together. So thank you for joining us. Any last questions before we wrap up?
Thank you.
Yeah, I just can't thank you enough. It was terrific.
Oh yeah,
Mm.
thank you for the invitation, and I could talk about this stuff all day, so I really appreciate having the opportunity, and I thank you for the back and forth and the great questions. Appreciate it.
All right. Well, thanks very much for taking the time and giving this. And, you know, I benefit. I get educated all the time. And I think this lecture will go far and be translate, and send a message and help others. So thanks.
Yeah, and my email's on the front if and always happy to answer questions, or if I can assist in any way, please let me know.
Thank you. The PDF to
Thank
share,
you
we'd
so
love to
much.
share that as well. Yeah, thank you.
And for my other colleagues, I'll talk to you all, I guess, next month.
Yes, looking forward to seeing you then.
Yeah, we still have to, as I know, I sent a note off and I'm working to some of your team members, because we still we'll work on clarifying what we all want to achieve in that next visit. So I look forward to that too.
Okay.
Thanks, everyone. Nice
Thank
to see you all.
you.
Thank you. Bye-bye.
Bye. Thank you
Bye.
so much.
Thank you.
Bye-bye.